This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe. Support for this podcast is provided by TearCare, a product of Sight Sciences. TearCare is a device that applies heat to the eyelids, where the current medical community recommends the application of a warm compress to the eyelids. Applications include meibomian gland dysfunction, MGD, dry eye, or blepharitis.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I am joined by my co-host Leslie Odell. And we are very excited to have a guest with us today, Dr. Art Epstein, who is originally from New York and received his degree from SUNY, where he was also the college's first resident in ocular disease. He relocated to Phoenix and also co-founded Phoenix Eye Care, and he heads up the practice's Dry Eye Ocular Surface Disease Center and serves as its director of clinical research. Unless you have not paid at all any attention to optometry publications, Dr. Epstein is very active in the profession. He's a fellow of the American Academy of Optometry. He is a distinguished practitioner of the National Academies of Practice. He's a diplomat of the American Board of Certification in medical optometry, is a member of the American and Arizona Optometric Association, and past chair of the AOA Contact Lens and Cornea section. He is a prolific author who has published hundreds of articles, scientific papers, and book chapters. Dr. Epstein, we are so happy to welcome you to the podcast. And we were speaking a little bit before, we were on an ad board together a while back, and I'm just really excited that we can meet again for this podcast. So it's a real pleasure having you here. So welcome.
Thank you. Thank you so much. Actually, I'm equally excited. Although listening to my bio makes me very, very tired. I think, right, wait a minute, I do all that stuff. I need a nap. But no, I'm excited enough. I'm kind of over the nap mode. So yeah, no, I'm excited to be able to share whatever insight you like with your audience.
And also insight is that, Art has been very influential, I would say, to my own career. And I'm sure you remember, and I talk about it quite often, but I read one of his articles years ago and emailed him, and he said, you should just give me a call. And so I remember even just being on the back porch of my house, talking to Art Epstein and thinking this is really weird, but he gave me great advice. At that time I was trying to get more involved in dry eye, and he said, if you want people to know who you are, write articles. And so I took your advice, and I would have to say thank you.
and here you are, actually quite successful and very well known. One of the great pleasures, and I was searching for the word, and pleasure really is the right word, is I've had the good fortune of having a number of younger ODs reach out to me, Mule Burgick, Dave Koenig, and I can go on and on, which I won't, but and I've had the opportunity to say, hey, I've gone through a lot of this myself, and here's some insight that I think will make it easier for you to get where you want to go. And when you have that kind of drive that you want to share your knowledge and educate, for me, facilitating that has been an incredible pleasure and an honor, because look at you, and look at a lot of other folks, Jackie, and there's a Yiddish expression called kvelling. It's like your chest swells up with pride when you see all of these young people really making it big, if you will, in educating our colleagues and becoming really relevant and making a difference for patients as well. So it's that part of it's been amazing.
Well, good. We're very happy to have you and have your knowledge for us today, because one of the topics we do want to cover is what do we do with this dry eye patient that, we can start treatment on this patient. What do we do with the patient that does not get better? We're trying this treatment, we're trying that treatment, we do this, we do that, and they just are not, they're not improving. Like, can you walk me through like your thought process on how you handle those patients and rethink those cases?
No, that's actually a great question, and for better or worse, I spend a good part of my what should be downtime thinking about things just like that. In other words, like, why isn't this working? How can I make it better? Why? How does it work? I think the fundamental problem in managing these failures really is a failure to understand all of the aspects of what we're dealing with. In other words, I think we, as a community, approach dry eye in a very piecemeal way. If you want to describe it in simple terms. In other words, a patient comes in and you say, well, I'm going to put the patient on an anti-inflammatory. I'm going to use, Restasis, or I'm going to use Xiidra, or the patient has meibomian gland dysfunction, and we make the diagnosis and we go, okay, I'm going to give them warm compresses and massage, and then the patient fails. And we think, okay, so I've done this, I've done that, instead of thinking what was wrong with the patient in a more holistic sense. More obvious to me than ever now is that dry eye is not only an erroneous term, because most patients who have dry eye don't really have dry eyes. They have tears that don't do the job they're supposed to do. But it is a complex, multi-layered, active puzzle. It's, at least 3, if not 4 dimensions, and time being among them. And if you can understand how things function, in other words, if you look at the original intent of the systems that maintain the ocular surface, and then you see how they're engineered in order to function. In other words, like, why do we have reflex tears? The reason why we have reflex tears is very simple. We didn't have manicurists or nail files or nail clippers and hand washing stations when we were cave people. So if we stuck our finger in our eye and scratched our cornea, we'd lose the eye, and that wasn't very good. So it was selected highly against, and we were built or ended up evolving, or however you want to look at it, with the ability to have this beautiful saline wash to wash something that got in our eye away, instead of us putting our fingers in our eye. So if you understand, okay, that's how that system works. So understanding how the systems work is critically important. If you are prescribing something, let's take an omega-3. I think most of us would agree that omega-3s are critical elements in managing most patients who have meibomian gland dysfunction, which is most patients. The question is, what is it that omega-3s do? You can say, you can use, lip service and say, oh, the anti-inflammatory, and they're good for tissue integrity and whatever. The reality is, omega-3s are the building block, specifically EPA, in my opinion, is the building block for meibum production. So if you have an eye that's deficient in EPA, or I should say, my meibomian gland that's deficient in EPA, the meibomian gland is going to struggle to produce meibum. So when I prescribe EPA, or rather when I prescribe omega-3s, I'm doing it intentionally, and knowing that I'm trying to give the glands access to more EPA so they can convert them into meibum. Likewise, when I'm treating a patient with an anti-inflammatory, I try to understand why I'm using, not that the eye is inflamed, but why is the eye inflamed? What specifically is inflamed? Is it because the patient's normal systems of maintaining function have failed, or is it because the patient has an autoimmune disease? So, when I look at dry eye, I look at it as a failure to maintain homeostatic control is the essence of the equation in dry eye. So a normally functioning eye is an eye that has numerous interacting, interleaving, interwoven mechanisms to maintain function. Produce too little meibum, you'll produce excess gel-forming mucins to stabilize the tears. So understanding that, I'm always looking to come up with ideas and understand how those things work to improve function and stability. So let's say the patient is on my foundational treatment, which is an omega-3, hypochlorous acid, and so on, and they don't do well. then I'm kind of looking at why they're not doing well. Are they being compliant? Is the patient actually taking what I prescribed? And I go to extremes to ensure that, give them checklists and things of that sort. Is the patient, does they need more? Maybe they're not getting enough omega-3. Maybe they're the odd person who needs, 4 instead of 3 caps. Is inflammation a significant factor? Are their eyes red? When they get up in the morning, is that the worst time of day for them? Have I missed that? Because that's a very common finding. So I kind of go back and look at the situation holistically and go, okay, so here's what I'm using. Here's what I think they need, and it's not working the way it should. What am I doing wrong? What did I miss? What do I need to do to make them better? Is kind of my mantra. And then we get to procedures, but I don't know if you want to get to procedures yet, but then we get to procedures when, more simple conservative therapy doesn't work.
So I just would say, I think that's some really great insight. I feel like maybe sometimes we don't even give patients enough time on a foundational therapy before we call it a failure. So I'd be interested to know, what's your return to office when you have a patient that you're starting on, say somebody who you're putting on anti-inflammatory, and does that look different from somebody that you're treating MGD and you're doing, nutritional supplements with omega-3 therapy?
Yeah, that's a great question, because you can undermine your own success by not having a good understanding of what you're doing, and how it works and how long it takes to work. So one of the things that I think happens is, over time, you really get a good sense of the tools you're using and how they function. So, for an omega-3, I'm expecting 6 to 8 weeks. So we typically will see a patient back in 6 to 8 weeks if that's the course I'm following. If it's an anti-inflammatory, depending on the anti-inflammatory, if it's lifitegrast, it's really active quickly. So, we're looking at, within a month, I'm expecting reduction of symptoms, and 2 months, some minor improvement in signs. If I don't get that at that point, I may stay the course. If the patient is having adverse experiences from the intervention, from the medication, for example, bad aftertaste, and it's annoying to them and they're not getting better, I'll discontinue it. I'm also always, I think the most important thing is when you have a patient back at that preset time that would be, optimal for seeing the effect of what you've done. Talk to them, ask them, what their experience is. Patients, or I always tell the patient, you're the most sensitive instrument in the office that we have, and we have an array. We have a ton of technology in the office, and we're always getting new technology. Literally have every expression device known to man. Don't use them all the time, but certainly have access to it. But by far, the patient will literally, if you're listening to them, they'll tell you what's wrong. If they say, my eye, feeling much better, I don't have the pain, but my eyes are burning, I'm thinking staph overgrowth and lipase production, which is causing saponification, so they're getting soap in their eye. So I'm kind of looking at the lids a little bit more closely. If a patient starts off really in bad shape, they've lost a good percentage of their glands, they're obstructed, there's inflammation, there's signs of ocular rosacea, telangiectatic vessels, I'm recommending IPL early on. So, I'm trying to be proactive, but at the same time, I'm trying to be reactive to the patient's experience. So I think that aspect, is important.
So, how do you handle, you have this foundational treatment that you'll start a patient on. And then let's say that you've given it appropriate amount of time and you feel like this is a failure. It's not actually working. And you're going to take the next step, whether this is, thermal therapy or whatever the next step is. I'm actually curious how your foundational is, what your next step is, and then your next step. Like you're like, what are your tiers on when you're treating a patient? And then I'm also wondering is when you get to that top tier and we've got no other therapies that you have in mind as far as treatment, and if a patient is still not improving, like where do you go? What's your thought process there?
Great. Actually, you're forcing me to think, which is good. Actually kind of unravel my thinking. What's actually funny is there's a zen to this. And I know that sounds kind of crazy, but and I tell this to patients. I go, if I take a look at you and I talk to you for a couple of minutes and I review the data, your mammography and interferometry and so on, and I know exactly what's going on, chances are fairly high this will be straightforward and you'll have no issue. If I get confused by something and it doesn't quite fit, you'll end up okay, I promise, because I don't give up, but I'll learn something in the process. And so every patient is an opportunity to learn something. So I actually love the patient that comes back and they're not doing what I expect them to do. It's like, wait a minute, why are you not better? So typically I am conservative by nature. So my foundational therapy is, relatively straightforward, probably similar to everyone else's. I'm a big believer in triglyceride-based omega-3s. Everybody gets that. I'm a big believer in hypochlorous acid for a number of reasons, reduced bacterial overpopulation, decreased saponification, decreased inflammation, blah, blah, blah. I do try other things. I'm not going to mention names of products that, your listeners are probably familiar with, because I don't want to say negative things about products made by friends, but I've tried pretty much everything and give it a chance. If it doesn't work, I kind of don't throw it away. It's still on the sidelines. And if everything else seems to be failing, I'll go to that. But when we see, when I see failure, I go, okay, so foundational stuff isn't working. I'll go to procedures typically. And again, the reason why is because generally I have success when I do that, so I already know what I'm going to be successful with under certain circumstances. So I follow those patterns if the breadcrumbs lead me in that direction. And so let's say I've decided I'm going to use IPL. So we'll do, 4 treatments. We have actually 2 IPLs in the office. We have an Optima M22 by Luminous, and we have a Luminous new OptiLight. And a lot of patients, I would say females, 95% will show significant improvement. And males, probably about 80-85% will show significant improvement after 4 treatments. Sometimes we do a 5th treatment because not everybody is created equal in terms of their response. The adjustment of the IPL, again, is kind of a Zen experience. I start out using the traditional FITS, guide, FITS skin grading guides, but then I'll kind of riff off of that. And let's say we get to the point where the patient is still having problems, then I'm going, okay, what did I miss? And then I go back to everything is under central control. Literally everything is under central control. Even reflex tearing is under central control, which is why we cry at sad movies, because the brain gets involved in the middle of that, even though it's designed to be a reflex immediate reaction to wash something away. And so I check corneal sensitivity if I haven't already. And I'm starting to think that maybe I should be checking corneal sensitivity on every patient. The amount of neurotrophic keratitis that we see in dry eye patients is actually quite stunning and often overlooked. And with the advent of Oxervate, we've taken severe dry eye patients that have converted over to classical neurotrophic keratitis and brought them back through the journey to NK, to dry eye, and out of dry eye on the other side. So sometimes we'll do that. We have a new device called the iTear 100, which I think is the most viable of all of the auto-controlled tear stimulating devices on the market. It's still in development. The next generation, I think, is not far off, and it gives patients the ability to control production of complete tearing. Now, to me, that's almost like a functional artificial tear. Artificial tears are, really one of the silliest things in the world. We say, oh, your eyes are dry, so here's a bottle of wet. How we ever got off on that craziness, I don't know, because that doesn't really, it solves nothing other than dilutes natural tears, which actually are helpful. But this is actually, if you've ever tested that or used one of those things, it's held up against your nose. It's a small little device, and it vibrates in a specific frequency. And suddenly your eyes are welled up with natural tears. I mean, if you look on a slit lamp and watch a patient, you can literally see meibum coming out of the orifices. It's quite remarkable. So I'm kind of excited about that. So we have lots of things to do, and sometimes it's you kind of realize you've just stepped in a hole and you have to pull yourself out of the hole. Sometimes you can prevent stepping in the hole where you don't have those I don't know what's going on moments. But since COVID hit, I don't think I've had a patient where I feel, that helpless feeling of, I don't know what to do. I've done everything I can. I think we've managed to address almost, not everything, because we're still learning, but almost all of these complex patients. And by the way, the last thing I'll say about that, one of the reasons why, is in this area, there's really no one to send them to. When you become it, it's like you have to, and that suddenly the pressure of that, in New York, I had, colleagues I can get other opinions from. Thankfully, I have a young associate who's great, and I know I'm sure there are other people in the Phoenix area who I could consult with, but just haven't created those relationships. But for the most part, they, when the patient is really like, oh, I've seen 18 doctors, and you're it. Oh, great, thanks.
This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Can you talk a little bit about that iTier 100? Because that's a newer device. I don't have any experience with it. Could you just talk a little bit like how often a patient will use that, and like how you obtain that device for a patient?
Yeah. It's actually it's really extremely limited distribution. I was actually at a Luminous event with Laura Perryman, and she looked at me and she said, "Oh, your eyes look terrible." It's just when I'm at meetings and things, that's not uncommon. As Leslie can tell you, she's seen my red eyes many times, and she said, "Hey, try this." And she's so bubbly and enthusiastic. She pulls this thing out of her bag and. And she says, "Just hold it over here," and it's like, and I go, "Whoa!" It's kind of shocking because you're taking your trigeminal nerve. It's like a cross between pulling a nose hair and inhaling snuff and God knows what else at the same time. I mean, not quite as shocking, but amazingly, the most impressive thing about it is your eyes suddenly are wet, and even more amazing. My acuity, was 20/20. It was typical 20/20. I guess we used to say during the LASIK, not very effective technology days. Oh, 20/20 is not important. 20 happy is important. Well, this was 20 really happy because I think I was probably about 20/10. I mean, my acuity became like insane because my tear film had become like an iron shield of refractive perfection. And it was like startling. It was like literally startling. And I felt better for, probably, good 2-3 hours. I've spoken to the inventor. He's a surgeon in California. They have very, very limited distribution. I don't think, and the problem is the FDA has approved it for only 1 month at a time, so it has to be sent back. So it is somewhat unwieldy in terms of its utilization. The next generation will be resettable via Bluetooth, with the doctor being able to reinstitute the prescription. And I think you'll probably hear a lot more about that, soon. To me, anything that gives patients control. I sue this, another great example. The patient has in their hand a little bottle when they're having a flare, when they're absolutely miserable. They can control it, and these patients, one of the problems they have is they're out of control, so giving them something that puts them back in control is actually quite impressive.
I think that you said it very well when you talked about all the, pitfalls that you might have had once with dry eye. And what really has been nice to see is just how companies have really been doing due diligence, doing the research, and really helping to fill the unmet need. Because I would agree with you. Some of the things that I now know a lot about, I learned by chance, like Demodex, for example. In 2012, I didn't really know a lot about Demodex, but I was treating my meibomian gland dysfunction. And when I would put them through certain clearing treatments, and then their symptoms would come back more suddenly, I was looking differently at their lid and, kind of uncover Demodex in my patients. But now I think that the companies also do a really good job of educating, the dry eye people, but also all of the optometrists and ophthalmologists out there that are willing to listen. And I've been learning a lot about this whole, the nervous system, and even just basal tear secretion and things you never really that I don't remember learning in school, that 34% of your tears come from just breathing air through your nose. Like, I didn't remember that. So it's been really exciting to see where technology and research has gone to help us not have so many pitfalls.
When I first opened the practice in Phoenix, I had this idea, and a very understanding wife. I think she thought I was insane, but she said, "Oh yeah, you want to do dry eye? That's yeah, sure." And in the beginning, there weren't enough patients to fill the whole day, so I would do routine care. But probably after about a year, I started not yelling at the staff, but saying, "Hey, no more routine patients, no more routine patients." And now I just see dry eye patients, but I go back to when we first opened the office. I didn't understand why no one in Phoenix was doing dry eye. My first assumption was I'd be competing with 1 million people for a small number of patients or a moderate number of patients. But the reality was that there was this massive unmet need because nobody wanted to deal with dry eye patients because they always failed. We had so few things to do, and who wants to deal with one of those annoying patients who never gets better? Of course, me, that's kind of my nature. I guess, I like self-flagellation. And, frankly, when we started out, there was nothing. I mean, we had Restasis, we had artificial tears, a variety of them. LipiFlow was around. We incorporated that almost immediately, and that was it. There was really nothing else. And to your point, Leslie, it's incredible how many companies have stepped up and gotten involved in this area, seen it as a massive opportunity to make a difference in patients' lives. I think many of our colleagues don't realize that this literally turns people's lives upside down. I mean, this is, I have people crying in the office, sobbing. Their lives have been so miserable. Sometimes they're ahead of the curve. I had a very bright young lady who's like one of the head HR people for Intel the other day, and she was in her 20s, late 20s, and she was already suffering. She was able to see what was going to happen, and intervened, and was very much into the self-help scene and so on. So the companies have been phenomenal with supporting education, with providing new products, innovating, and I think someone getting out of school now who's interested in dry eye thinks, oh, this is great, we have all these tools. We didn't have those tools 10 years ago. I mean, this has been a fairly recent development.
Can you comment on the patients that are non-compliant? Like, we all want our patients to take omega-3s and do hypochlor and all of that. But what do you do with the patient who comes back and is like, yeah, I haven't been doing that, and they're obviously not better? What's that conversation like with that patient?
First of all, before you answer, it's always interesting that patient that is non-compliant has come back. They do. That's even another part of the puzzle to me.
Yes.
What's interesting is I find that they do come back, but usually they come back, later on when they've already gotten themselves into deeper trouble. They need that, that second warning, like, that klaxon going off, and they go, okay, maybe this person was right. Maybe the doctor was right. It's interesting. When I started out, I don't want to sound like this is only within really the last, 10 years or so when we opened a practice. So this is recent experience. I was, typically, lazy New York doctor transplanted to very hot Phoenix. And I would tell people what to do, and had the delusion that if I told them what to do, they would do it, because New Yorkers think that if you actually say something to someone, that they'll actually listen to you, which of course they never do anyway. So I would say, well, here's what I want you to do. I want you to do this, and I want you to do that. And I took a little sticky pad, a little typical sticky pad, and I'd write out, blah, blah, get this here, get this there. I didn't want to carry any of these things because it was a pain in the rear. And I just wanted to do clinical care, not the other aspects of it. And the patient would come back in 6 to 8 weeks, and I say, oh, so how are you doing? And they go, no, terrible. No improvement at all. No, nothing. No, just maybe worse. So I go, are you taking the omega-3? And they go, what omega-3? And I go, well, we talked about it. I talked about triglycerides versus amylesters. I'm very big on education, by the way. So when you mentioned reflex tears before versus basal tears, every one of my patients, I tell them you're going to get a PhD in dry eye, because sometimes you have to tone it down because they just don't have the bandwidth to fully understand it. But I think the more you give them, and the more you can relate it to their life experience, like structure of the basal tears, structure of a house. I always use that analogy. But I discovered that the genius idea that I had of using a sticky pad wasn't working. Apparently, it wasn't sticking. So I came out with a pre-printed checklist, which has been modified, I don't know, God knows how many times, probably 20 or 30 times as I've discovered new things and, refined my procedures. And I go over that with them. So the end of the exam is at least, 5 to 10 minutes of reviewing not only what I want them to use, but why I want them to use it. And believe it or not, the compliance rate is extremely high. I mean, I'm talking, 95% initially. It tapers off. It probably goes to, 60, 70% over time. And those are the patients that end up coming back in a year or in 8 months or something where they're having trouble again. Because at the end, when I'm done, I like patients to be, when I let them go for an entire year, I want them to be stable and doing well. So I think ensuring compliance is a matter of giving them very specific directions, something that they can take with them. And it's not, I know, Oculus came up with something where you could print out like 80,000 page forms. Patients don't want 80,000 page forms because what they can do is put them in the garbage. They want a single sheet that they could put on the refrigerator or something of that sort that they can refer to and then reference it again. I'm thinking of actually having a follow-up sheet as well, just to kind of reinforce that. But I think that plus education empowers them to follow directions, and it creates a bond. I probably shouldn't share this, but probably about a year ago, it's a good ending, I think. 2 years ago, I said to Shannon, who's my associate and wife, and puts up with me, I said, I don't understand it. I mean, I am taking these patients that in a million years, if you asked me 10 years ago, 15 years ago, would I be able to help them with this work? And I would have thought you were crazy. And these patients are all doing well. It's the most incredible thing. She says, I know. I said, I don't understand how I'm doing it. She looked at me and she said, you're a Svengali. So I said, what? She said, yes, you're a Svengali. You spend a lot of time talking to the patient and you convince them that they can actually get better. And you give them the steps to do it. But by convincing them that they can get better, they actually do get better. They have a path to getting better. And I think that's probably the best advice I can give everyone. Believe in yourself, believe in your ability to make a difference in someone's life. Always measure your success or failure by the outcome of the patient. It's not about you, it's about the patient.
And now for the To The Point wrap-up. Dry eye disease is very complex. Your nervous system and immune system are constantly regulating the balance of the tears to maintain homeostasis. When homeostasis breaks down, that's the challenge of our job, to figure out where that breakdown's coming and how best to implement your strategies to improve the outcomes for the patients. Listening to your patients will also help to guide your treatments. When all else fails, reach out to a mentor, much like Arthur Epstein, someone who's been in the trenches doing the work for some time. We're here for each other. Let's not forget that.